Welcome to our third lecture of your point of care ultrasound series. Thank you for joining us today. We are going to begin looking at some different ultrasound modes that you will be using in your clinical practice. And so hopefully we'll give you some strategies and some understandings of these that will help you be successful. So the outcomes for this week's lecture are to explain the different operating modes of sonography and the common applications of each mode. The first mode that we're going to start with is our B mode, which can be really referred to as our black and white or brightness mode. Then we'll discuss M mode, which is the mode evaluation of motion. Color mode, which superimposes color over objects demonstrating motion. Spectral mode, which presents velocities and flow as a function of time. Power mode, which is another type of color mode that has a little greater sensitivity, and then our 3 and 4D modes. So first off is B mode. Now this is first because this is the most common scanning mode that we utilize. So B mode is just general grayscale imaging, and the B is for brightness or black and white. This is a 2D image production, or the representation of a slice of anatomy in a 2D image. And how we present this or create this slice of anatomy is really dependent on the orientation of the operator's hand. So if this, for instance, this pregnancy image we have here, if this was taken at the mid-sagittal plane of the female patient's body, the length of the transducer would be in line with the mid-sagittal plane, making this a longitudinal image. If we looked at this longitudinal image, then what was towards the curve of our curvilinear transducer here would be the anterior aspect of the patient's, or the surface of their abdomen. What is posterior here would be towards their spine. Now, if this was in longitudinal orientation, what's to the left of the image is towards the patient's head, what's to the right of the image is towards their feet. Now, if this transducer was turned 90 degrees so that the face of the transducer was transverse or in an axial presentation to the pelvis, again, what's towards the top of the image is going to be anterior to the patient's body. What's towards the bottom would be more posterior to the patient's body or more towards their spine. What is to the imaging operator's left would be the patient's right, and what's to the operator's right would be the patient's left. And so these B mode images really collect information as a slice and represent it on the image. Now, how it's represented on the image, or the brightness in which it applies to a particular reflection, is going to depend on the strength of that reflection. So if this transducer emits sound waves that are all basically in equal amplitude, and that sound wave comes down and it interacts with an object, let's say in this case the fetal face, and that object has a high impedance like we discussed last week, that high impedance would cause a large reflection. And as that large reflection came back, it would be demonstrated as a high amplitude sound wave. The high amplitude sound waves are represented with a very bright dot on the image, whereas low amplitude sound waves that might come from this uterine wall would be represented by a lower echogenicity of the dot. And so with our B mode imaging, it's created by dots representing echoes. Areas where no echoes returned from are what we call anechoic, or black, as you see here. And if we want to compare the brightness of different dots, we can use terms like hyperechoic or hypoechoic. So if I wanted to compare this fluid to the fetal face, I would say it's hypoechoic to the fetal face, and in fact it's so hypoechoic it's nearly anechoic. If I wanted to look inside the fetal brain, and I could say that fetal brain then would be hypoechoic to the fetal face, or the fetal face would be hyperechoic to the fetal brain. So those are some of the terminology that we're going to be using in our B mode scanning. It's really important to remember that the brightness of the dots are dependent on the amplitude of the returning echo. Some important considerations we have to have when we're completing our B mode scanning is we have to have the understanding that areas of high tissue attenuation will not return echoes or will absorb so much of the sound being that there will be nothing left to return. So the basic definition of attenuation in ultrasound is tissue that either scatters, reflects, or absorbs the sound wave. And when the whole sound wave is scattered, reflected, or absorbed, such as here, then it takes away all of the sound that would then be used to produce deeper echoes. And when that occurs, we get something called shadowing or acoustic shadowing. Sometimes it'll be called posterior shadowing. So this is an example of a likely breast mass, and it doesn't have a huge reflection. So we know if we're losing all of our sound wave in the far field, then it must be either scattering or absorbing this. And in this case, because we don't see a lot of scatter coming into other regions of the transducer, this must be absorbing it. And malignancies have the more common feature that they will be highly absorbent and will sometimes create shadowing. So this would be a concerning sign, is that posterior shadowing in a breast exam. Now, there can be areas on the second image here where you see that we have a gallstone. Now, this gallstone is also attenuating. We know that because there's a big shadow. Now, this gallstone is not so much attenuating by absorption, but it's actually very echogenic, so it's reflecting back all of the echoes, leaving no echoes to propagate to the distal field and therefore creates a shadow. So that's one of the significant features of a gallstone, is that that shadow can demonstrate that it truly is a stone and not something like a polyp. Now, on the opposite end of this spectrum is the case where we have something like this cyst here that has an anechoic material within. And so as we emit sound across this whole face of this transducer, and all the sound progresses through the tissue, the sound in this region and the sound in this region are going to be attenuated every step of the way. However, the sound here in this central region will reach the cyst, and once it's in the cyst, none of it will get attenuated. So when we get to this more posterior field, we see that we have more echo or more amplitude in our sound wave down in this region than we do here and here, because no attenuation occurred in this particular portion where the cyst is present. So because of that, we will have more sound waves interacting, and those sound waves will create what we call posterior enhancement. So that posterior enhancement is considered an artifact, but it's one that helps us recognize that whatever lies anterior to that posterior enhancement has no or low attenuation qualities, whereas when we have shadowing, we know that whatever lies anterior to that shadow has high attenuation qualities, and that attenuation could either be scatter, reflection, or absorption. Sometimes these artifacts can be very helpful in diagnosis, like I mentioned, when we have a cyst, and we know cysts are very anechoic, so they produce posterior enhancement. That would let us be more confident in our assessment that this was truly a cyst and not some other type of anechoic mass. However, if we come up here, it's quite the opposite. Here we have something that looks just like relatively regular echogenicity, and yet it's producing a large shadow. That tells me that this particular area has some high attenuation qualities that I'm not seeing anywhere else, which would cause a reason for concern. And then the same thing can help us identify these gallstones and watch and make sure that they are mobile and help us really determine that they are truly gallstones and not some polyp or other differential diagnosis. That brings us to M mode, or motion mode. M mode is the presentation of motion over time on a display. It depicts time and depth and allows for measurements. This is one of the more common modes utilized in cardiac scanning. Now, as you see here to the right, this is a typical M mode image. So this would be looking at the left ventricular outflow tract of an echocardiogram. And you see that this line is running through the right and left atria. And as it does that, it's collecting motion information all the way down the length of the line. That motion information is then plotted along the y-axis here over time. And so when we look at this, we can correlate the anterior wall correlates to this motion here. The intraventricular septum correlates to this motion here. The valve correlates to this motion here. And then the posterior wall correlates to this motion here. And so it allows the depiction of multiple different tissues moving over time. The other thing that can be useful on this, that is often used in cardiac scanning, is they can actually be measured. So the motion lines here would actually correlate to the thickness of that intraventricular septum. This could correlate to the width of that right ventricle right here, and so on and so forth. So it's a lot of information presented with motion over time. So that brings us to color Doppler. So color Doppler is basically the superimposition of color over a B mode image where motion is detected. Now, the way that we detect motion in sonography is by utilizing something we call the Doppler shift. This is the same sort of technology that they use in for police officers assessing speed with radars. So what we know from Doppler shift is that when we emit a sound wave, and that sound wave interacts with something that is moving, it will change the frequency of the sound wave. So if this is my transducer here, and we know that it emitted a sound wave that had a frequency that looks something like this, and it interacted with an object moving toward it, that object would cause an echo. And that echo, because the object was moving towards it, that echo would then return with a higher frequency than it was originally emitted. That change in the two frequencies would cause what we call a Doppler shift. Now, if the frequency went from a lower frequency to a higher frequency, we would call that a positive Doppler shift, and that would indicate that the motion of the object was toward the sound wave. Now, on the other hand, if I had an object moving away from the propagation of my sound, that sound would have to chase that object down, but when it eventually hit it, it would return an echo, but that echo would have a lower frequency than the initial sound wave. Now, the change in the difference between those two frequencies would cause a negative Doppler shift because the second frequency would be lower than the first frequency. So our system, through some amazing calculations and through the Doppler equation and something called autocorrelation, is actually able to assess these Doppler shifts very, very, very quickly and analyze and apply color to where Doppler shifts are detected while producing a B mode image behind it where it's looking for just general echoes and not assessing for Doppler shifts. If we look at how the Doppler shift scale works, here's an example over here on our right of what a color scale on your ultrasound image will typically look like. And on that color scale, it will have a baseline, which is a general, just a blank area. Above that baseline will represent anything that's a positive Doppler shift, and below that baseline would represent anything that was a negative Doppler shift. So in looking at this kidney here, we see that the technologist has put on some color, and we see that we get a lot of red in this region all through here. That would indicate that blood in that red area was moving up in to the kidney. Whereas the area where we see this blue blood, that would indicate that that blood was moving away from the kidney, indicating this was probably venous and this was arterial. Blue toward the transducer in this case, red toward the transducer in this case, blue away. Now, That doesn't always have to be the case. There is controls on every machine that allow you to invert that color scale where you can make it look blue toward the transducer and red away. But the standard practice, or usually the starting point, is with red toward, blue away. So as I mentioned, the color Doppler really is based on the same sort of Doppler principle that radar guns use to detect speed. And so if this ambulance here that we see here was, say, moving away from this particular police officer, and he was shooting his radar gun towards this ambulance, his radar gun would be sending out a sound wave at a particular frequency. When that frequency hit the ambulance, it would be reflected back, and because the ambulance was moving away, that reflection frequency would be less than the primary or functional frequency. Whereas if this police officer up here was sending a sound wave from his radar gun, it interacted with that ambulance and reflected it. That interaction would cause an increase in frequency, representing a positive Doppler shift, whereas this would have been a negative Doppler shift. So those positive and negative Doppler shifts then are applied to color based on the color scale like we looked at in the last slide. Now, one of the things that we do find, and you can see here in this particular image, that the beam mode image is in the background, and then this bright green box here is angled over a particular vessel. Now, if you notice, that bright green box is not lying straight up and straight down, but it's angled to one direction. When we're angling this box, what we're doing is we're timing our transducer pulses so that it is actually sending out its sound waves in an angle. Now, this angle, when we look at here, the sound waves are going out like this. So, if I look at this blood flow, if the flow were to be going this direction, it would be running away from the sound waves and would cause a negative Doppler shift. But if the blood were to be going in this direction, it would be crashing into those sound waves, causing a positive Doppler shift. If my color scale was demonstrated with red on top and blue on the bottom, I could look at this image and say, sure enough, my blood was moving away or toward the sound waves. In this case, the blood would have been moving toward. If my red was on top, my blood appears red here. That tells me it was moving toward the sound waves, and thus it applies the red color. So a number of different things can be detected and understood from the appearance of color Doppler on your imaging system. So the color Doppler provides information on movement, including the presence of motion, the direction of the motion, and to a certain extent the velocity of the motion. Now, if we look over here and you were to see your color scale right in this region here, you would see red is on top, so that's red is toward the sound wave. Blue is on the bottom, blue would be away from the sound wave. If we look over here at our image, we can see the scale, or pardon me, the color box is angled this direction. So our scan lines are moving something like this. And if red indicates toward the sound waves, this red would indicate that the blood flow is moving up toward the patient's head. So the other thing that we can detect is you will see on your scale, and this one's a little bit small to appreciate it, but you'll see a value here where at the top of the scale would read something like 60 centimeters per second. That would be the maximum scale of velocity that the color could demonstrate. So if I saw something in this bright orange hue, I could say, oh, that must be going nearly 60 centimeters per second. If it was lighter and lower and closer to the baseline, I would know that it was less than 60 centimeters per second. This can be very helpful when you're coming into a stenosis and you see elevations begin to rise. it can show you where the fastest parts of the flow are for when you go on to take your spectral Doppler, as we'll talk about shortly. So so it can tell us the presence. So the assignment of any kind of color is going to determine presence of motion. The direction of motion requires us to take a look at where our scan lines are going and assess by looking at our Doppler scale if it's coming toward or away to determine the cephalic or the caudal nature of flow. And then finally, the velocity, like I said, depending on the hue, it would indicate major changes in velocity here. It can be difficult to optimize your color Doppler. Some of the things that you do have to watch out for is, number one, is the scale. So as I mentioned here, this would have a maximum velocity number here at the top and a minimum velocity or a minimum negative velocity here at the bottom. Now, if I was getting values that exceeded what I had set on my scale, what happens is something called aliasing, where anything that was beyond that, say 60 centimeters per second, anything that was faster than that would be represented by a blue. It kind of does a wraparound. So in order to prevent aliasing from happening, you have to have an appropriate scale set. So one of the most important things that you're going to do when you're utilizing color is set your appropriate scale, making sure that all forward motion is indeed classified with the correct color and that you're not demonstrating any aliasing of the color. The second thing that you can change is your baseline. The baseline, as you see, is right here in the center of the two colors. You can set that lower or higher depending on the flow that you're looking for. But most of the time, if our baseline is set too high, we'll have difficulty detecting any flow. If our baseline is set too low, we would have excess flow or artifact demonstrated. So keeping it towards the center is typically the best approach. However, if you're having difficulty getting adequate sensitivity, then that might be something that you would decrease that baseline. Maybe if you're having difficulty picking up any flow at all because it's low, you might decrease that scale. So those are two things that you would have controls on your system that you could adjust scale and baseline. When I'm having trouble getting color, the first thing I go do is turn my color scale down until I feel like I'm getting artifact, and then I would bump it back up just enough to correct that artifact. And then finally, steering is going to be really important. And when I say steering, I'm referring to my color box, such as you see here. Your system will have controls that would allow you to steer that box to a number of different degrees towards the right, as in this case. You could also steer it back, and so it's a perpendicular box. And then you could even steer it the opposite direction, so it would be a particular number of degrees to the left. As you practice using your steering, you're going to see certain positions are going to optimize your visualization of flow, and so that's definitely something that you want to work with because of the science of Doppler effect. It's really important that you get your box steered correctly in order to appreciate as much Doppler shift or color as possible. So the color Doppler overall allows for also improved placement of spectral mode Dopplers. So we'll talk about this momentarily, but just very briefly, you can see here on this image that this isn't just a color Doppler that you're seeing running down the center of our vessel here, but you're also seeing that it's accompanied by this spectral Doppler that presents velocity and directional information of the blood flow as well. So the utilization of color Doppler really helps us to outline that vessel, and so you can see that what we call the range gate, or this little area here, is set towards the center of the vessel to get you optimal spectral information. So now that we've kind of looked at how we demonstrate flow utilizing color Doppler, it's really important to kind of have some knowledge about the principles of flow. Now, fortunately, the principles of flow really follow a lot of our common sense experience. So if you've ever worked with a PVC pipe or a garden hose, a lot of what we see with the principles of flow in the body system are going to correlate to our experiences in those situations. So, and I'm sure with your vascular knowledge as a provider, that a lot of this is going to be review. So we'll go over it rather quickly, but when we get into the spectral mode, this information becomes very pertinent. So for principles of flow for our vascular system, there has to be a change in pressure in order for flow to occur. So without any change in pressure, we would just have stasis of fluid or blood or water, whatever the fluid may be. The flow rate, or how much flow is occurring at a particular site in a particular amount of time, is going to be determined by a number of different things. First of all, it will be determined by the viscosity of blood, which when we compare the viscosity of blood versus the viscosity of water, it is slightly higher. However, how it acts with flow is very similar to how water would. It certainly isn't along the lines of, say, honey or anything like that. It really has mostly the same properties as water. On top of having viscosity affecting flow, we also have a pressure gradient affecting flow. So we know that if we have, a PVC pipe, and I were to have that PVC pipe lay straight across a horizontal surface, and I were to fill it with water, the water would just spread out in that PVC pipe, but it wouldn't necessarily flow one direction or the other. If I were to pour water into this particular pipe, because of the difference in pressure between the incoming end and the outgoing end, I would have a lot of flow going in this direction. So pressure gradient, or a difference in pressure, is going to be a significant feature in what causes blood flow. Now, perhaps one of the most important parameter when we're talking about flow is the diameter of the lumen. So this really comes into play when we're looking at vascular ultrasound, in that if I have a nice broad vessel such as one here, it is going to allow flow to kind of move through it nice and slowly or easily, whereas if I have a narrower vessel up ahead, the speed of that flow has to increase significantly to maintain the amount of movement through that area as through this particular area. So our area, or the diameter of the lumen, has a significant impact on the amount of flow that can occur at that lumen. And then finally, resistance. So resistance in our vascular system is mainly controlled by the arterioles. So our arterioles are going to be reacting to neurologic feedback to cause vaso and arterial constriction and dilatation, and that is going to change the blood flow that we see in our vessels. So of all of these qualities that affect flow rate, area has the highest impact. However, all of them are significant factors. One of the most significant factors, as I mentioned, has to do with area, and it's due to something called the law of continuity. And the law of continuity really states that if I have a particular amount of blood flow going through an area or a lumen this size, and I have to maintain that flow, but my lumen has decreased in size. In order to accomplish that feat, I will have to move the blood flow through this area at a much higher velocity than I had to through this greater area. So that's the law of continuity. And when we're seeing patients that have stenosis of an artery or something of that sort, what we see is the flow will come along the typical vessel nice and regularly, and then as it gets into the stenotic area, we see these huge increases in velocity, and that's how we're able to find the most stenosed area of a vessel. Now that would be usually due to some sort of pathology, but we know that our vessels really provide a number of different resistances depending on the needs of the tissue bed that they're feeding. And so arterioles really accommodate those differences by reacting, producing vasoconstriction or vasodilatation to meet the tissue's needs. So if we look at some of the types of flow that we see occurring with our color flow, and inside our vessels. The first type that we want to talk about is laminar. And laminar is basically referring to just like laminated plywood or laminate countertop. It's something that's arranged in layers. And so our laminar flow really has our components of our bloodstream moving in parallel, uniform flow to one another. Now, there's a number of different types of laminar flow. This initial one that you see where basically all the blood components are sliding parallel to one another and they're all moving at basically the same velocity or speed, we call that plug flow. Now, if plug flow occurs down a very long vessel, which is relatively uncommon, but if it does, what happens is the friction between the blood flow and the walls begin to slow down the blood flow slightly. And as it does that, the blood flow will change from this laminar plug to a laminar parabolic shape. Now, another thing that can happen is if I were to have a vessel, such as, say, the carotid, and it bifurcates into our internal and our external carotid, and blood was flowing nice and laminar down the common carotid, and then it breaks off into half going to the internal carotid and half going to the external carotid, and yet the blood components maintain that parallel uniform appearance. They just diverge in a new direction. We would just call that disturbed laminar. Now, here in this vessel, you see that we're coming along as a plug. Friction starts to take over, so we move to more of a parabolic laminar, and then all of a sudden we get to a dilatation of this vessel. And when that happens, there's all this extra space, and so rather than just moving forward, straight forward, in the nice laminar organized flow that it came in as, that's where we start seeing turbulence, which I'm sure you listen to with your stethoscope and different things, but we can actually see it with our color flow patterns to help us appreciate this. So we get this turbulence, and then eventually it will get straightened out and hopefully get back to laminar flow as it progresses down the vessel after that stenosis. Okay, another type of flow is pulsatile, which you're used to listening to, I'm sure, but when we're looking at it on Doppler, with our Doppler sound waves, or with our color Doppler, or with our spectral Doppler, as you see both here, you will see that pulsatility as the flashing of the blood in the artery. Whereas if you're next to a vein, you'll see the vein is much more phasic, meaning it's changing with respiration and thoracic abdominal pressures, but it's not responding in most of our veins to the pulsatility of the heart. So this is a right common carotid artery that we have a waveform here on, and so we definitely appreciate that, that pulsatility of the arterial system, where we get a systolic peak, early diastole, late diastole, and then a new systolic peak. And we can appreciate the pulsatility as we go through that system. So while color Doppler is a phenomenal tool, we often find that we utilize it with spectral Doppler as well. So spectral Doppler you may also hear called duplex scanning, because it's using a B mode image with color and spectral Doppler, so we call it duplex. When we're using spectral mode, spectral allows a quantitative and qualitative analysis of blood flow, and it can directly or indirectly describe pathology. So sometimes we will get a signal right within a stenosis that tells us this is a stenosis. Sometimes we'll get a signal on our spectral waveform that says, oh, this is not right. It's not showing me exactly of a stenosis, but it indicates that there was a stenosis either coming up or a stenosis that I just have passed. So we can either see a stenosis change, or we can see indirect signal of a post-stenotic event. When we look at our spectral Doppler waveforms, we're really looking at the x-axis is going to indicate time, and then our y-axis is going to indicate velocity. So just as we saw on our color scale, it was listed with the velocity, a maximum velocity here, a negative velocity here, and then it would demonstrate everything within this scale. Even though we can't see it on this particular image, a spectral Doppler would have the same thing, where we would have a maximum velocity up here and a minimum velocity down here, and we could adjust that scale to accommodate the velocities that we're getting. These are extremely helpful. This is extremely helpful information. So the waveforms not only demonstrate or can determine the velocity of blood flow in a particular area, but when we have the understanding of what normal waveforms look like in a particular vessel, and we take these, we can tell from not just the velocities, but also from the shape of the waveforms, if it looks like there may be pathology ahead or behind where we're scanning. Some of the things waveforms can demonstrate are a range of velocities existing at each moment in time from the sample area. So if you look very closely at this particular image, you will see that there's a white bar here and a white bar here, and we can call that our cursor or our range, our spectral range, or our gate. Now this gate can be opened broader or closed more, and we utilize the color to kind of direct us in where we want to set the gate. We know that we will get the most accurate general blood flow information if we set the gate right in the middle of the vessel. So here we have our range gate right here in the center of the vessel, and again we can open it or close it. Well, when I hit my spectral on button, it will start collecting velocity information just within this cursor, and it will depict the range of velocities that are occurring within this cursor in a particular moment of time. So if I had velocity of blood consistently moving through here and it took a reading and it gauged that there were velocities between, let's say, about 120 centimeters per second all the way down to some turbulence in the negative velocities, it would draw a line representing all of those velocities. However, a moment later during diastole, this same cursor would be taking in information from the Doppler flow, and it would recognize only a few negative velocities or reversal of velocities. And so you should see that represented with a very small reversed line. As we go forward, you would see that sort of pattern would continue until the next systolic contraction, and then you would see ranges of velocities from this maximum number all the way to the minimum number. Now, sometimes your velocities are not going to have such a large range. Hopefully, if you have a nice, clear common carotid artery, you'd have velocities between about 80 to 70. And so it would just represent those velocities in that range at that moment of time. So that's how our spectral display is created, by taking that velocity information in this particular area at that particular moment in time. Now, we know that the resistance that we can see can also affect the shape of the spectral waveform. So without knowing exactly how much background you've probably had in this, I hope I won't be boring you, but I'll briefly go over what some of our resistances appear like. So in our spectral Doppler, if I have a very low tissue bed with good arterial dilatation, I would see something that would have a good systolic upstroke, and then it would slow down during early diastole, and then in late diastole it would be pushed forward some more, as you see that this is above the baseline, and as the Windkessel effect, or as that potential energy from the arterial system contracts and continues forward motion. And then the next systolic stroke would begin, blood moves forward, blood slows down at the end of systole into early diastole, and then that potential energy of the arteries again squeeze the arteries, moving blood forward again, creating forward flow through diastole. Now, if I had something that had a significantly higher resistance, it would look something more like this. I would have forward systolic motion. At the end of our systolic upstroke, what we would then see is, so then, as I mentioned, during early diastole, we're going to see it taper off. And because there's a lot of resistance ahead, it can even cause the blood to reverse flow before having that potential energy from the arterial system kick in and push it forward. And so this would be a higher resistance waveform where we see good systolic upstroke, but we have early diastolic reversal. And then the resistance is not so high that that potential energy of the arterial system can't overcome it. So once that potential energy kicks in, we get that forward motion again. Now, in a situation where we have a very significant stenosis up ahead, what you might see is a huge increase in resistance where we would get systolic motion forward, but you see it's much slower because it's pushing against a much more resistant area. And then in diastole, it's going to drop right down to 0 or reversed. And then in our late diastole, the strength is not able to, the strength of that arterial potential energy is not able to overcome the resistance ahead. So you would see no forward motion throughout the rest of the cycle until you had your next systole. What we call this with the slow upstroke here is tardus parvus. So we get a tardus parvus systole, early diastolic reversal, no end diastolic motion at all. Now finally, if we were following a stenosis or past a stenosis, and that stenosis really was not letting the adequate amount of blood or the expected amount of blood flow through, what we might end up seeing in that case would be something that's very low resistance. So in this case of a post-stenosis blood flow pattern, what we might see is during systole, there's not the same volume of blood that there was pre-stenosis. And so we'll again see kind of a tardus parvus waveform. And then because there's just a lack of blood, it's basically going to drop down to the baseline. Nothing will occur until the next cycle. And we call this a monophasic waveform. Now, some other really important concepts that we have to know when we're utilizing spectral Doppler is that it is very what we call angle dependent. And so, as you saw on the previous slide, we typically will have a cursor, and we're going to put that cursor inside a vessel. And then what you'll see inside that cursor is kind of one long line. The idea of what this long line is within the range gate or the cursor is that we need to make this long line our angle. Our angle, or our spectral angle, should be parallel to the angle of the vessel, and it should be less than 60 degrees, as we're going to talk about here shortly. The range gate then are the two cursors that we see on either side of the angle. You have the ability to open up those cursors, making them wider, or close them down, making them narrower. And when you have a narrower range gate, you typically get less interference or less artifact. We want it optimally in the center of the vessel. Now, when we hit the spectral on button, what will happen is it will be only taking the blood flow measurements with velocity measurements within this gate. Okay, the Doppler angle, as I mentioned, is represented by this long cursor that runs through the gate. Now, ideally, when sound, as you can kind of see in this particular image to your right, when sound is propagating at either perpendicular or exactly in line with the motion of the blood flow, you're going to get the maximum or minimum negative Doppler shift. So if I have blood coming straight at my sound wave, that's when I'm going to get the maximum positive Doppler shift. Whereas if I have blood flowing directly away from my sound wave, that's when I'm going to have the maximum negative Doppler shift. So 0 degrees is a really good angle to take your Doppler, spectral Doppler information with, because it gives you that optimal Doppler shift. This is an example of how a portal vein here is being assessed with Doppler at a 0 degree angle. Now, most of the time, it's almost impossible to get a 0 degree angle when you're trying to utilize your Doppler scanning. And so what we do is we make sure, number one, that if our vessel is running across our screen and we set our gate, we make sure that the angle within our range gate is parallel to the vessel. If our angle is not parallel to the vessel, it will affect our inclination or our angle of approach to receiving our sound waves, and we will get inaccurate velocities. So step number one is getting that angle set and parallel to the center of the vessel. Now, one of the reasons this is so important is that our Doppler angle, like I mentioned, is going to affect our velocities. So Doppler angle and the Doppler shift depends on the cosine of the angle of incidence. Now, if we have a 90 degree angle, our cosine is 0. So our feedback of our Doppler motion is going to be 0, and we won't get any signal or any information on our spectral or color Doppler. The larger the angles provide less Doppler shift. The smaller the angles provide more Doppler shift. So one might think, well, 0, 10, 20, 30 would be the optimal angles of intonation. And you would be right at the 0. However, 10, 20, and 30 tend to send a sound wave out, have that sound wave basically skip off the vessel wall and bring back no useful information. So your optimal angles are actually 0 degrees or straight up and down at the vessel, if the vessel's up here and I want my angle coming straight up and down, or 30 to 60. So 30 to 60, right in this vicinity here, allows us to get our sound wave into the vessel more efficiently than we could at 10 and 20, but not have such a significant angle that our cosines will affect our velocities, such as they would in 70, 80, and 90. So your keys to getting accurate velocities are utilizing a 0 degree or a 30 to 60 degree Doppler angle. And again, when we say Doppler angle, it means that line between the center of our range gate. Okay. So if we were to kind of break this down in step-by-step process, what we would want to do is make sure that the Doppler angle is arranged parallel to the vessel wall. So you can see that's well done here. Doppler angles there, walls there. Sometimes I feel like my eyes aren't that good at detecting parallel orientation. So sometimes while I'm scanning live, I'll put that angle there, make sure to get it parallel, and then move it to the center of my vessel. Now, when you have your angle set here, you will have a readout on your system, and you can see it right here, that tells you what exactly your angle is at. This one demonstrates that this one's at 44 and this one's at 64. Now this one would be over 60, so that would indicate that I need to decrease that angle. If we got that angle decreased all the way down to 44, then that would be within that 30 to 60 range, and we would know that our velocities would then be accurate. If we look at proof to guarantee that that is true, we can look here and we can see that these systolic velocities are occurring at about 80 centimeters per second, whereas this one is 60. So by having that excess angle, we actually added 20 centimeters per second to our velocity measurements that were inaccurate. So it's really important, this makes a huge difference, it's really important that we first set our cursor parallel to the vessel. Second, check and make sure that our angle is less than 60 but over 30 or at 0. And then thirdly, if we cannot get it parallel and with the appropriate angle, what we often have to do is what we call heel toe, or move your hand down and angle up to get the vessel more angled across your screen so that it matches that Doppler angle when it's less than less than 60 degrees. Now, depending on how much experience you've had with this, this might be moving too fast. Maybe it's something you're completely comfortable with. So in not knowing exactly where you lie with the experience in this area, I'm not sure if this particular lecture is going to be meeting your needs in all respects. So please reach out to me, especially if you have any if you could use any additional help when we're talking about Doppler, spectral, and color, because this does seem to be one of the more challenging parts to get really confident in ultrasound. Okay, so we talked a lot about color and spectral and some of what we can see from them. One of the things that's going to make color and spectral a really useful tool rather than a really frustrating experience is utilizing the controls that are going to help you optimize these. So one of the first controls we look at is steering. So steering, this is the one that we talked about with, especially with our color usage. This is when I could steer my color box one direction or the other to optimize my color flow. Remember that if we are using a color box at 90 degrees to a vessel, we won't get any feedback because all of the sound will basically be reflected off the vessel wall and back, and we won't have any information to get, or any ability to get information within that vessel. So steering of your color box is going to be extremely useful. This is an example of a GE system. Oftentimes your steering is going to be right here on the color panel with both your Philips and your GE. With some of the point-of-care ultrasound systems, it can be a little bit trickier to find, so let us know if you need help in doing that. Secondly, our color map. Our color map, as you see right here, is located anytime you have color Doppler on and anytime you have color and spectral on. So this is our color map, and in this case it's showing red toward, blue away, meaning that red is going to represent my positive Doppler shift or anything that's crashing into my sound waves, whereas blue would represent anything running away from my sound waves. Now, an important note to make here is that as an operator, you have the ability to invert this color map. So let's say that you've got red toward, blue away, but your vein appears blue, and you'd feel much more confident or comfortable if your artery appears blue, but you'd feel much more confident and comfortable if it were to be red. Rather than changing all of your box angling and heeling and towing and all of that, you can simply invert this color map. It's important to recognize what inverting it does, because if you are really concerned about direction of flow, then you would have to really assess what's moving toward, what's moving away, and how that affects the normal vascularity of that area. Gate, as I mentioned, gate is really our range gate. So when we run our spectral line down there and we set our gate in the center of our vessel, we have the ability to open that gate to make it wider or narrow it to make it narrower, and just realize whatever Doppler shifts we're looking for with our spectral is going to be read from that particular gate. Our baseline of color is right here. Our baseline of our spectral is right here. If I was getting if I didn't have enough velocities to demonstrate how, if my scale over here was too low and I wanted to increase my scale so that I would have higher velocities appear on my spectral Doppler, I could adjust that and increase that scale. That was what we have next on the line here. If I had velocities in my color going faster than what my maximum velocity is here, then again, I'd want to increase that scale. Now, if I increased that scale and I had everything moving forward above the line and nothing moving below the line, and so this would be very hard to detect because it could be very small, and I'd have a lot of blank space down here. In that case, I can adjust the baseline, moving it downward to optimize my visualization of what's happening above the baseline. We can do the same thing with color. Now, one thing I didn't talk a lot about, but Doppler, it detects all motion. We really use it for vascular assessment, but another thing, it can be used to look for urinary jets coming into the bladder or any other kind of motion in the body. The system is not that brilliant that it can differentiate tissue or urine motion from blood flow. So we have to be aware that we're always going to detect motion besides vascularity. And so the wall filter is a way where our system can actually show color in the vessel wall because the pulsatility of the blood flow coming through will cause that wall to move. And when the Doppler shift in that wall is detected, it will assign a color to it. So if I wanted to make sure and get rid of the color that's in the wall and only apply color to my Doppler flow, then I could set something called a wall filter. And that would filter out flow that was external to the vessel. Okay, and then finally, flow. Most of your systems will have a way to set some general qualities of flow. So if I'm looking at a very high flow area, such as the common carotid artery, I would just have it set at high flow. And that would automatically adjust my scale to higher velocities. It would adjust my baseline and whatnot. Now, if I was, say, in an ovary trying to detect flow on a possible torsion, it would not be as high velocity, it would not be as apparent, it'd be much more difficult to pick up. Most of your systems will have something like high, medium, and low flow to set your settings at to kind of adjust the scale, the baseline, and the sensitivity without having to make every single individual adjustment. Okay, another mode. So after our color and spectral Doppler, we have something called color power Doppler. Sometimes it's called color angio or power angio. And this is a very useful mode that we can use, especially in low flow areas. So this is a comparison. We're seeing the aorta here, the IVC here, the liver here. They're all relatively high flow areas, so we can pick up flow and direction in that area pretty easily. But here we're seeing the hepatic veins dumping into the inferior vena cava. And while there's a lot of flow here, it's usually very slow flow. So it might be harder to detect on your regular color Doppler ultrasound. So power Doppler is a great option. Power Doppler is going to be a little bit more sensitive, number one. And number two, it's not directional dependent. So when I put my color on here, I don't have as many things to think about if I just want to see if there's flow or not. So this works really well in certain areas. It's great when you're working on an ovary. You don't really care about the direction of flow. You just want to see if there's flow there. It's got very low flow. So your color power or your power angio, that can be very helpful in scanning areas with low flow. That brings us to 3D mode. So as much of a buzzword as 3D has and is over the last probably 30 years, the usefulness of it is variable. So, you know, once you're used to looking at images in our regular 2D and you're able to scan through anatomy and make your own assessments, you get less dependent on 3D. But it still can be a very useful tool as you see it being used here for a uterus, or actually a number of different uteri. So what the 3D does is it basically takes a scan of many, many, many different 2D images and collects all that data at once and arranges it into a volume. Then it allows the operator to utilize that volume to scan through in coronal, axial, and sagittal to obtain any angles that they weren't able to get in live scanning. So in the uterus, it's very difficult in your typical scan to get a coronal view of the uterus. And that's one of the views that you would best see the endometrium. So here you see a number of different uteri that were scanned in 3D, and then the operator was then able to remove the volume, anterior or posterior, to the endometrium and then assess the endometrium with none of that distraction. So here you see a relatively normal uterus. Here you see a unicornus uterus. Here you see a significantly septated uterus. This one's another septated uterus, another septated uterus. Here is the T-shaped uterus that they see with DES exposure. This one has a little bit of an arcuate change, and this one is uterus didelphus, and this one's your bicornuate uterus. So you can see how, especially with uterine anomalies, 3D mode can be very, very useful. But again, it often takes quite a bit of manipulation after the acquisition of the volume. Now 4D mode is really 3D mode with live scanning. This is the most popular one that we see offered at fetal photos and different places like that. This is where we get more of our surface rendering. And so here you see a lovely little fetal face, and we really obtain these by setting the surface to render anterior to the face, and then it would collect images all the way across in a sweep, and then it would create a volume out of those images and demonstrate it with the surface and in live time. So you can see the fetus, sucking, moving, all of that, because it's in that 4-dimensional mode. So now the AIUM does not recommend fetal photos for anything other than diagnostic purposes or as part of a diagnostic scan. So there's a lot of ethics that really are in consideration when we get into these fetal photo type situations. And so if that's something that you are interested in or inclined to do, I do recommend that you take a close look at the AIUM ethical standards regarding this. But it is another available mode and one that can be very useful. And once you're comfortable with it, it usually takes just another moment of exposure after your general scan is done. All right. Well, I have an error here in my summary slide, so I apologize for that. Please disregard this particular slide. And thank you so much for being with us today. I hope that you'll find this helpful. If there's anything that you have questions on or anything I can clarify, please let me know. I know it's kind of a lot of information crammed into one chapter. It is very useful information, so hopefully you will find ways to implement it in your scanning. So thank you. Have a great week.